going to talk about today really piggybacks off of many of the themes that we talk about in the video. So, as you know, my name is Susan Loughnane, and I've been a Creighton fertility care practitioner for almost 20 years. And I usually talk freestyle, but I'm going to stick to my notes because there's some key areas that I want to make sure that you get today. So at the end, if we have time, we can certainly do questions and answers and delve a little bit deeper. Now, my husband and I personally used this system for at least 16 years, and I benefited from NaProTechnology when I struggled with severe PMS, called PMDD, and hormonal imbalances. Now, I want to personally thank Ashley and Dolores for inviting me to speak today. I can't tell you how excited I was to be able to do this. We've had some fantastic conversations over the last couple months, and I felt a little bit challenged. We're preparing this not because I don't know the topic area, but there's so many great things that I could share with you. So I hope today to touch on a few of those. It really represents hope for women and couples in our region. Now, I love storytelling as a way of getting points across, and as I share these stories with you, number one, I want you to keep in mind that I'm trying to highlight that there's an alternative. There's other options for treatment of some of these issues. So it will highlight the differences maybe between standard medicine, how somebody is trained, and what NaProTechnology might do a little bit differently. My story is one of the second ones, and it really speaks to why I do the work that I do. It's funny, there's times when I think I can't do this anymore. I'm not going to do this anymore. And then God will send somebody into my life that reinforces that I will never be able to walk away from this. So the first story involved a couple who came to me, or this was one of my very first clients. I think it was client number 9. And they had had 9 years of primary infertility. They'd been to the best fertility doctors in Pittsburgh, and I'm pretty sure they had done just about every test in the arsenal of tools that they had to offer them. Yet somehow they were given this diagnosis of unexplained infertility. Now, as an aside, I personally love these cases because I try and reassure them that it's not really a diagnosis. There's still a lot of things that we can investigate. So the wife had had at least one documented miscarriage. We think she might have had another, but we know there was one documented. Once she began charting, really within the first 2 to 3 follow-ups, we saw biomarkers and signs in the chart indicating a risk of low progesterone. She also was seeing very limited cervical mucus. Now, typically, the medical consultants, a NaProTechnology medical consultant, will want the client to have 2 months of good charting on paper before they do the referral. It gives them enough information, to make further decisions on. So when she got to that point, we made a referral to a NaPro medical consultant. Now, just as an aside, you saw 3 of the doctors in the video. A NaProTechnology medical consultant could be a physician, nurse, midwife, nurse practitioner who's undergone the medical consultant training through the St. Paul VI Institute. Now, often their specialty may be obstetrics and gynecology, but we have internists, family medicine. In fact, when I watched this video for the first time, I didn't realize that Dr. Nolte was family medicine. I thought she was obstetrics and gynecology. We even have pharmacists, nurses. It's really a range of medical personnel that go through the program. So the obstetric gynecology specialty, of course, these doctors would be able to offer the full range of services, including surgical services if needed. And ideally, that's what we want to attract to this region, is an OB-GYN who has gone through the complete training and can do these surgical procedures. So getting back to our patient, she was first put on mucus enhancers to help improve the quality of her mucus cycle. And she actually achieved a pregnancy by, I think it was by like the third, 4th month of charting. Now, since low progesterone was a concern, her levels were measured, and she was put on progesterone support the entire pregnancy and monitored. She delivered a full-term, healthy baby girl, and it was amazing to me that in all of her previous fertility visits, that no one even asked about her cervical mucus, whether she had it, how good was it, nor did they try and evaluate the quality of that mucus. In addition, the progesterone issue was fairly easy to diagnose and straightforward to treat. Now, many mainstream doctors will be okay with progesterone support in the first trimester. That seems to be pretty commonplace. However, what we see is that they often bulk beyond that when we start talking about second and third trimester. And there's some reasons for that, but it has to do with using bioidentical hormones versus other types. So I won't go into that detail, but suffice it to say that we have many women that need progesterone support the entire pregnancy. My daughter-in-law, I have a granddaughter now, and she is a NaPro miracle baby. Now at this client's, they invited us to the baptism, and I mean, there was not a dry eye in the house. You know, everybody truly cried tears of joy for this family, and really it's very humbling to actually be a little bit part of that journey that they're making. Now the second story is my own story of severe hormone dysfunction, and I share it because again it does illustrate some differences regarding evaluation and treatment. I was a bit of a reluctant NFP'er. Prior to my marriage, my doctor told me that I should go on the pill to regulate my cycles. And I thought, oh, okay. He first was kind of in disbelief that I wasn't sexually active as a single female, and told me, well, you're going to need it anyway. Once you're married, you're going to need the pill. So I took it reluctantly. Nobody ever told me why I shouldn't, but within less than a year, I developed moderate cervical dysplasia. There was one time when I heard the doctor throw around the term precancerous. And that was it. My husband, we sat down, we read the insert, and kind of gasped at the side effects listed that nobody had really shared with us. And then I watched my husband walk over to the garbage can, throw the pills in the garbage can, and said he didn't want me taking those anymore. So we both somewhat cynically attended an intro session. We were stationed in South Carolina at the time to learn more about this NFP stuff, and I can echo what Dr. Hemphill said. I walked out of there dumbfounded. I had learned more about my body in that 1 hour session than I ever knew. I had 2 kids already. You'd think I would know this. And I came away from that with the belief that all women deserve to know this information and understand their bodies in this way. Now to fast forward a bit, I had always struggled with PMS. It would ebb and flow at various times in my life, high school, college, early adulthood. I dealt with mild to moderate postpartum depression after the first 2 children's births. And for years, I had observed a multitude of thyroid-related symptoms: fatigue, weakness, intolerance to cold, hair loss, anxiety. It became kind of a running joke because I would go in and tell my doctor these symptoms. They would do the TSH tests only. Oh, well, you're normal. Everything's normal. I had times when my immune system would go into kind of a hyperdrive, and I was continually trying self-help measures. I exercised, tried stress management, made nutritional changes. I did Tai Chi, I did weightlifting with Nautilus machines, read a lot of self-help books in the process, and talked to a lot of people in the process. I had essentially about 5 good days in the month where I felt reasonably human. And when I was 2 or 3 days premenstrual, look out, it was Jekyll and Hyde. I used to hide myself in the bathroom at times because I feared what would come out of my mouth and how my rage would impact my kids' emotional stability. I had not only the emotional symptoms, I would black out, low blood sugar at times, hypoglycemia possibly, and when you study this whole area of PMS, there's about 150 symptoms that can be associated with or exacerbated by PMS. That was news. I thought that was fascinating. Now, during my 3rd and last pregnancy, I was sick almost the entire pregnancy, and there were a number of red flags that should have made me think about how unstable my hormones were. Now, after Matt was born, I nursed him for about 14 months, and I had to stop due to going on gallbladder medicine. Cycles returned around that time also, and I remember thinking that if this is what PMS is going to be like, just lock me away now. And I had this belief, you know, if I just did everything right, if I ate right, if I exercised enough, if I did all the right things, I could manage this on my own, you know, as I had done for years. Now, 3 days after I stopped nursing, basically I plunged into deep depression, and I became almost agoraphobic, like not wanting to leave secure, safe places. I eventually contacted my practitioner, who was in South Carolina when things got really bad, and I'm not going to go into all that detail, but suffice it to say I got copies of my chart. I composed a letter to Dr. Tom Hilgers at the then Pope Paul VI Institute and asked him to evaluate my case. Now, Dr. Tom Hilgers is one of the co-developers of the Creighton system of charting, and he is the developer of the science of NaProTechnology. Once I received a reply, the first thing they asked me to do was a targeted hormone evaluation. And this is distinctly different than the standard way that other doctors had tried to test for hormone levels. Now, typically a doctor will say, well, go have blood drawn on day 21 or 22. That may or may not be at the right time, depending on how long the cycle is or where you're at in the cycle. So a targeted profile relies on a woman accurately identifying her peak day according to Creighton guidelines, and then having blood drawn on peak plus 3, 5, 7, 9, and 11. This gives a much more accurate profile of what's really happening during that entire luteal phase. My post-peak hormone levels were rock bottom, as we like to describe it, literally baseline. It explained a lot. And I had to have them repeat the levels to me on the phone, because at that point I had just convinced myself that I was an anxious housewife, that all women had this, I just would have to learn to live with it. As the nurses explained, and they mentioned this in the video, if I was diabetic, I would manage it with meds and the appropriate treatment. PMS is a legitimate medical condition that can be treated. So my treatment involved something called Cooperative bioidentical hormone therapy, and I did some other supplements as well. I mean, I could do a whole talk just on PMS. There's so much more to this story, but the reality is that I believe Dr. Hilger saved my life. To give you an idea of the nature of this NaPro doctor, I was getting ready to undergo the targeted test, but had some confusion with my cycle and where to start. And I remember that morning being curled up in a ball in the corner of my bedroom due to severe anxiety. So I called, and when you're in that state of mind, I didn't realize the time difference. And so when they transferred me to his home number, I think it was like 5 or 6 a.m. in the morning, he did not yell. He did not chastise me, as another doctor had done with my very detailed questions. But he calmly took a breath and he sighed. He said, this can happen sometimes. He then carefully explained how to proceed properly with the test. And at that point, I knew I had found a doctor with great compassion, a program with great compassion, who cared about women's health and would point me in the right direction. And I never looked back. Now, up to that point, I'd probably been to about 7 or 8 different doctors, and no one knew what was happening in my body. I literally became a human guinea pig. I took a variety of different medications, gallbladder, Giardia, gastrointestinal related meds. It became a bit ridiculous. My family doctor all along had a feeling that thyroid was involved, even though I was showing, normal TSH. She explained that there were other more in-depth measures, and she referred me to an endocrinologist. So I had one appointment with the best endocrinologist in Richmond, Virginia, after a 3-month wait. I had sent a letter prior. I thought it would be helpful for him to see this is what we've done up to this point, just explain a little bit about my symptoms. So, when he walked in the office, he was kind of flustered and kind of just, kind of angry. And I mentioned, asked him if he had received the letter. He said, it's in your file, I didn't read it anyway. I didn't have time to read it. And then he looked at my Creighton charts, and he kind of leaned over, he said, those are pretty. Had no idea how to interpret anything on the charts. So literally about 5 minutes of talking to him, he walks out, brings me back the name of a doctor. It was a psychiatrist. So this was his way of dealing with it. Let's just pass the buck. Now, little did he know, I was already seeing a counselor, and the counselor also believed it was hormonal, and she was really pushing me to find the right doctor to get this evaluated. Anybody that knew me knew that this was not my nature, what was happening, the symptoms. So my therapy with NaProTechnology did involve the HCG injections, which they spoke about in the video, but they were timed accurately during the luteal phase. So by identifying my peak, I knew when to do that cooperative therapy. In addition, I used estradiol post-peak, and when you use it post-peak, it does not act contraceptive in nature. I had progesterone support. I took DHEA support, which I still to this day take that supplement, and also took something called naltrexone, which has a very fascinating history. Just to share a little bit about that, it helps with the anxiety component of PMS for many clients. They also now are seeing very great success with naltrexone in autoimmune patients. So very exciting history. There's actually a woman at Penn State who has done, I think she has a website on what's called LDN, low dose naltrexone. So it's been used in infertility cases. It's really a cool medication, but that's not its original
Susan, who was prescribing, which doctor then was?
That's a great question, Dr. Hilgers. Everything,
Okay.
when I went through the targeted profile, everything was prescribed long distance, but he never would do anything unless we had actual blood work and tests to document the levels. So.
And it was all because your hormone levels were super low?
Yes.
Okay.
Yeah, for some reason when I ovulated, I just was not producing estrogen and progesterone. And there are traditional theories about PMS do talk about progesterone, but we do find in some women that, again, the beta endorphin levels can be low, which can give women a lot of anxiety. Estrogen can be low, like I would have brain fog and just, a lot of symptoms related to low estrogen.
But you were getting your period and everything, or still having a cycle even with that level?
Yeah, pretty interesting. So this is just two stories about how NaPro was able to pinpoint the underlying causes of the reproductive and hormonal issues and provide real hope to women. Now I'm going to talk about some other comparisons a little bit later, but I want to just briefly talk about some definitions because you'll hear Creighton, NaPro, some people think it's the same, they'll hear acronyms. So I want to share with you 4 key words or acronyms. So first, Creighton Fertility Care System is simply that. It is a system, it's a holistic system in which women and couples can learn to monitor, maintain, and evaluate the woman's health. Now the Creighton method of charting is a medical model of fertility awareness. And it's part of this system, but when I teach somebody throughout the course of a year in our course, it really does include a lot more than just the charting. Charting is a big part of that. NaProTechnology is the actual gynecologic and reproductive science. So Creighton is the health system, the holistic system. NaPro is the science. It's a shortened term for natural procreative technology. It's designed to take a disease-based approach to finding underlying causes of various conditions. It works cooperatively with the woman's body and never does anything to destroy or suppress fertility. The Creighton chart is a foundational tool for NaProTechnology. Now you'll hear people say NaPro and NaPro. It's like tomato, tomato. Dr. Hilgers actually says NaProTechnology, so that's what I've always used, but you'll hear people say it both ways. Now there's 2 major organizations that are part of our world in Creighton and NaProTechnology. The first one is FCCA, and this stands for Fertility Care Centers of America. So once a practitioner completes their training program, they may opt to join an already established center, or they may decide to set up their own center. These centers must be affiliated with the FCCA. My center, Western PA Fertility Care Solutions, LLC, is part of the FCCA. So each year I have to renew this affiliation. I have to commit to their ethical and moral guidelines. In addition, I provide data on client categories, client load, those kinds of things. Now the other acronym that I want you to know is AAFCP, and this stands for the American Academy of Fertility Care Professionals. I'm actually an active member of that. We have different levels of membership within the organization, but essentially this group is the certifying agency for all practitioners, centers, medical consultants, and education programs. The responsible practitioner of each center has to be certified, and this is renewed every 4 years. Initial certification was pretty intense. A lot of paperwork. I think I got it in the day before the deadline it was due, but mine just was renewed this past October and November, so I'm good for another 4 years. Now the AAFCP also does a yearly educational conference in which I can earn anywhere from 13 to 18 continuing education units. I love these conferences. The material, the speakers that we received this year was an especially good one. I think we had some really awesome speakers, but this is really important to my ongoing certification. If I don't pass certification, I can't teach, and I can't order supplies. So it's very important to continue that aspect of it. Now the St. Polycystic Institute used to be called Pope Polycystic Institute, and it is in Omaha, Nebraska, and we consider this our home base, our headquarters, so to speak. Again, as I mentioned before, Dr. Tom Hilgers is a co-founder of the Creighton system. He and his wife, Sue Hilgers, met Drs. Lynn and John Billings many, many years ago and became very interested in this field. His story, without going into a lot of detail, pretty interesting. He was at the Mayo Clinic, a senior resident, his last year, and they wanted him to do abortions, and he said absolutely not. So he actually had to leave that program and then try and find somewhere to finish his medical education. So that's what brought him to St. Louis, Missouri. He and his wife met Ann Preble and Diane Daly. So the four of them were the co-developers of the Creighton system. Now, NaProTechnology is actually part of the bigger movement that you're seeing not only in the United States, but throughout the world, called Restorative Reproductive Medicine. When we have our conference, typically the day before, the IIRRM, and I think it stands for something like International Institute of Restorative Reproductive Medicine. But this has a very positive connotation when you hear that, restorative reproductive medicine. The notion of protecting fertility and not seeing fertility as a disease, but rather a normal process in females and couples. Now, when I was preparing this talk, one of the things I did, we have a private practitioners page where we have some medical consultants on the page, practitioners, great discussions, great way to talk about cases without still observing privacy. So I went out and I asked, I said, okay, all of you who are doctors, nurse midwives, nurse practitioners, can you share with me kind of what your training was like and just some key points? And I must have hit a nerve because within 20 minutes, I think I had about 10 responses. So I highlighted just a couple things. One of our nurse midwives mentioned a midwifery textbook. Varney, I guess, is a standard text. She said it's like the midwife Bible for treatments for all medical conditions. And she said basically they list the birth control pill, more or less. Some alternative treatments are listed, but barely. This response was a little more biting or crisp. She said, 1, any gynecologic abnormality, treat with oral contraceptives. 2, anybody who is normal, treat with oral contraceptives. 3, not genitally active, give them oral contraceptives, or better yet, put in an IUD and maybe throw in some antidepressants. Women's cycles are always 28 days and they always ovulate on day 14. Not. If they fall pregnant, abortion is a great fail-safe, one of her professors said. She quoted her professor as saying, abortion is safer than a shot of penicillin and 40 times safer than a colonoscopy. Infertile, give them Clomid, and if that doesn't work, just send them for IVF. IUDs are not abortifacient. Meanwhile, on the same slide that was said when they talk about the MOA, the mechanism of action, it says it thins the endometrial lining. Well, if it thins the endometrial lining, there's a possibility that a new life, would not be able to implant. Other nurse midwives and nurse practitioners talked about how the pill was standard of care, for things from cycle regulation, abnormal, irregular, unwanted bleeding. IUDs have become a mainstay of treatment. They're highly advocated in core midwifery texts. Infertility education wasn't too slim, but included nothing about cycle education other than 28 days, ovulation predictor kits, temps, etc. Now, I thought this was a really lovely statement. She said, being able to apply Creighton model and NaPro during school and as beginning practice is very free. It allows for practice independence, focus on each woman's particular needs, and authentic physiological feedback. So those were just some of the few comments. Now, I want to talk more about some of the differences. So we've already mentioned the targeted hormone evaluation is one area that's done differently. The way progesterone is used to support is done differently. We classify the mucus cycle, the quality and the type of mucus. So when we're talking about infertility, I want you to think of a triangle, and there's 3 key points to that triangle. So the first is usually the targeted hormone evaluation. Now, sometimes in infertility cases, not only will they look at the luteal phase, but they'll also look at pre-peak to see, is there estrogen dominance? What's happening with estrogen during that pre-peak phase. The second corner of that triangle is the ultrasound series for ovulation assessment. And this is designed to assess possibly 6 ovulatory defects. So not only are we concerned with, is the woman ovulating, but is she ovulating well. That's really important. You know, many times clients will call and they'll say, oh, I'm using those ovulation predictor kits and I know that I'm ovulating on this day. So I'll tell them, well, explain to me a little bit more about what you're saying. So those ovulation predictor kits do detect LH in the urine. Now, whether that means they're ovulating, that's yet to be proven. So there's times when actually they may show an LH rise, but they may not actually be ovulating. Or they may be ovulating, but the kit doesn't really tell them about the quality of ovulation. Are they ovulating well, essentially? So that ultrasound series is really beneficial. And I do find that some of my clients have had maybe an isolated ultrasound to check on the size of the follicle, that type of thing. But the ultrasound series really allows our doctors to get a more complete profile. The third corner of that triangle is something called a diagnostic laparoscopy. This is done to evaluate the condition of the uterus, to evaluate the presence of endometriosis, pelvic adhesions. So let's briefly talk about the differences. So with standard medicine, many physicians have told me, well, yes, I was trained to do a laparoscopy, but essentially it was to learn how to do a tubal ligation, not necessarily to look for endometriosis. A near contact laparoscopy is what's done in the field of NaProTechnology, and this can often reveal endo to varying degrees, and we can also see other things in the area such as pelvic scarring, adhesions. If you think of a camera with a zoom lens, and I've actually seen slides, some of our doctors have presented slides from their surgeries. So with a standard laparoscopy, you look at it, it looks beautiful, everything looks fine. So think of a zoom lens on a camera. When you get in there and you zoom in, then you can really look at the surface, and what it looks like is almost like little brown spots. I would never have known that that would have been endometriosis. So the near contact procedure really allows them to do a very thorough procedure. Now, many clinics now, I know out of Camp Hill, Dr. Dax was using the Da Vinci robot. This is awesome. It allows surgery with really good success, better recovery times. When we talk about endometriosis, another difference has to do with the type of surgery and the anti-adhesion procedures. So excision surgery has the best outcome because it takes endo out from the root. NaPro doctors only do excision surgery. They don't perform ablation. Ablation comes with a high incidence of growth back, like every 4 or 5 years. Now with excision surgery, there's an 80 to 85% rate of endometriosis never going back. Now I'd like to mention that the Institute, their anti-adhesion rate is better than the national average, and that's a concern when you have surgery. You know, are adhesions going to form? So I've had doctors explain how they actually close that, you know, do that repair and do that procedure. They use some type of vortex material. It's really fascinating, but the beauty of it is it really helps to prevent adhesions from forming. So this is something that a NaPro medical consultant who goes through the surgical training, they would know how to do this. As they mentioned in the video, the IVF industry really doesn't look to figure out the underlying issues. They want to get the couple pregnant. But if the underlying issue is not diagnosed, think about the implication of that. If the woman has underlying concerns or problems, then she's at a very high increased rate of miscarriage. And I've seen this happen, where women will say, you know, I've had 4 or 5 miscarriages, nobody seems to be able to figure this out. Now, male factor infertility, this definitely can be a legitimate issue, and NaPro has a different way of gathering the sample for this. So the way that a NaProTechnology medical consultant would recommend obtaining a seminal fluid sample would be something called a perforated condom. So what this means is the perforation allows a natural active intercourse. It's not considered contraceptive, but still allows the collection of some of the semen for analysis. So instead of the typical recommendation where they hand them in a cup and basically point them to a bathroom, this is a much more dignified way, I believe, of obtaining the sample. Now, cervical inflammation. Some women may have a condition that's related to cervical inflammation, and typically in their charts, what we'll see is a continuous mucus pattern. Now, most most doctors, OB-GYNs and internists, it's not really a big deal for them because most of their clients are not charting. But for women who are charting, this can make it very difficult to determine when is my true time of fertility. So by looking at the chart, one of the things I'm trained to do is to look for specific biomarkers at certain points of the cycle. And we can predict with about 70 to 75% accuracy if there's a degree of inflammation present. Now, in some women, it may be more related to hormonal dysfunction. That was a running joke with my doctor because I had the criteria, and every time I'd say, well, just check and see, is there cervical inflammation? And she would shake her head and say, there's no cervical inflammation. But again, the beauty of this is if we identify this, we can treat it. It helps the woman to manage her chart more clearly and helps to lessen the continuous discharge, if not eliminate it. Now, many of you have probably heard of Polycystic Ovarian syndrome. So this is something that I've read some articles about the idea of changing the name of this syndrome to reflect metabolic syndrome because there's a lot of different things that are going on. Now, in standard medicine and in NaProMedicine, metformin has been used successfully with some women. Now they're actually seeing success with something called myo-inositol. We've had a couple women that have been on this and have had really good results. In addition, many doctors now are looking at the functional side of things. What about anti-inflammatory diets and nutrition? Is that beneficial? And they have seen good success with that, so that's something that might be recommended. Now, there is a surgery called OWR, ovarian wedged resection. This was popular years ago. It was very successful, and for some reason it was kind of abandoned as we entered the pill era. But our doctors have done this all along, and this is where they go into the ovary. They actually make like a little pie incision, kind of open up that space. It can be extremely helpful, and I've seen a number of cases where women have had this surgery, and once they've healed, they've been able to go on to have children. Now, progesterone supplementation. Dr. Nolte talked about cooperative progesterone replacement. So if the woman is charting, again, we can time accurately when this progesterone is being administered and not just randomly. I've actually had clients that have come in to me and said, oh, well, I'm taking progesterone every day of the cycle. So I'll kind of pause and keep a straight face and say, well, tell me more. Help me to understand why they told you to take it every day of the cycle. So it really should be taken in the luteal phase, and when it's taken the entire cycle, it often messes up their charts and causes more problems than what it helps to solve. So this is another situation, again, where the charting is really a foundational tool. Prematurity, infant prematurity. The Institute has specific prematurity prevention protocols, and this is something that NaPro really excels at. Dr. Hilders and his staff have often commented that the prematurity rate in the U.S. is disgraceful because this is something that can easily be treated. Now, there's a whole host of issues when you think of prematurity: financial, the effects on the baby, the health of the baby and the mother, so preventing it is definitely worth something worth pursuing. So this is just a few of the areas. You'll notice this is my favorite book, the textbook. I am a nerd. Love reading this thing. He's actually working on a revision of this original textbook. But when this came out, I believe it was 2004, 2005. And this was extremely beneficial because now there was a resource. So we actually have had doctors that will maybe contact the Institute. There's information on progesterone levels, where should the woman's levels be. So this has just been a great resource. Now, some of the other resources that I have, I do sell these books when I go to events. So Women Heal, this was one of the first publications. My story's in here. My story is also a very edited version of my story. But Women Healed is about women who pursued NaProTechnology. So there's all different types of case stories in here, and really great information about, often people will read this and say, oh, that could be my story. That sounds exactly like what I was dealing with. Now, if you don't want to read the medical textbook, this book is a great resource, the NaProTechnology Revolution. So it's kind of the layperson's guide to some of the stuff that's in the textbook. So the beginning part talks about the system, talks about the charts, and then it goes into, again, case histories and studies. So this has been a really favorite book among a lot of our clients. clients and one of her couples. So I'm going to stop there. There's tons of other things that I could talk about in the textbook, things like ovarian dysfunction and ovulatory disorders and adenomyosis, but I really wanted to open it up for questions and have some discussions if there's things. Often when I'm talking to people, I forget sometimes that, I often talk to people who do this type of work and understand what I'm talking about. Sometimes people say, I didn't really get what you meant, by that comment. So if you have questions, please feel free and we can talk. And
so when you're counseling, first of all, thank you very much.
You're
That was
welcome.
wonderful and very informative, so appreciate you sharing your stories and everything. When you're working with couples here in Pittsburgh or in the area, then are you able, how are they getting hormonal support, progesterone support?
Great
How are
question.
you working with area doctors?
So
How does that work?
I don't really work with area doctors because we don't really have anybody currently. We used to have, Dr. Eileen Kumont used to be in White Oak, and she was, I think, internal medicine, so she was able to do some of the blood work at times. But I'll be honest, most people, by the time they get to me, they kind of are at that point where they just don't believe that anything is going to work for them at that point. So the first thing I try to sell them on is the value of learning how to chart their cycle. Second, I try and identify, really try and be proactive. If I see, like I had somebody the other day, first follow-up, I know this is going to be a NaPro referral, like hands down. So I start preparing them, to get ready for the referral. And I have learned how to present the notion that, yes, we have these specialists in the state of Pennsylvania. Yes, they are in Harrisburg, Camp Hill. What is your insurance plan? I hope it's not UPMC, because UPMC is considered all out of network. So oftentimes if they say, Highmark or Aetna or one of those, I get very excited because it's more likely that they will pursue it. So there are different options. If they want to write to Dr. Hilgers and submit their case to him, they can do that. With my situation, I didn't require surgery, so we were able to do everything long distance, and there are some physicians, NaPro physicians, who will treat long distance. Not a ton, but there are a few. The Camp Hill, that's probably where the majority of my referrals go to. We try and get 2 months of charting, and I start working on referral even prior to that point. So one of the services I provide is something called a referral packet. So it's basically a 1-page form that Camp Hill has given to me to kind of summarize the case. And then I also add a 2-page case summary letter. And the nurses out there, they're so funny. They're like, oh, I love this. Like, we've actually paraphrased and copied parts of your letter to go into our report. So they have to be seen. At Camp Hill, they have to be seen in person at least one time. They will not treat long distance. And that's to protect them and also to protect the patient. So once they are seen in person, many of my clients will do phone follow-up or email follow-up. Now, if they want to schedule them for surgery, they will work with the couple to try and find a time. Sometimes they might do it, include a weekend in that time period, or if it's a teacher, maybe they can do it over the summer break. So they really do try and work with them, to try and get that in. But honestly, once couples go out there and meet with these doctors, somebody the other day sent me an email and she said, Christine was awesome. She said, it's the first time I felt like I had a lot of time to spend to talk to them about, what's been going on up to this point, and there's actually a direction that they have or an idea of what direction they want me to head in. So I've had people go out there for surgeries.
But if you identify, just based on your experience, that it's a progesterone issue or something like that, you can't just get a doctor or work with to get them hormonal support. It has to be all referral. That's what you're doing.
That's what we've been doing currently. So, and I always stress too that the chart is a valuable tool, but one of the first things I tell them, I cannot diagnose from the chart because they'll show it to me and they want me to do it. And I wish I was that brilliant, but no, I'm not a physician, so I really do try and stay in my area, my specialty. But the way that we explain it in our follow-up form, the back page is all on NaProTechnology biomarkers. So for example, if I see a short luteal phase, if I see tail-end brown bleeding, if I see premenstrual spotting of a certain length and variety, I will explain to them there's a correlation with a possible increased risk of low progesterone, increased risk of miscarriage. So we kind of phrase it in those terms. So it doesn't mean that it absolutely exists, but it's worth pursuing to try and find out. There's just all kinds of things. The whole mucus issue. I mean, I had a client once that was going to fertility doctors and she was not producing enough cervical mucus. You have to have cervical mucus to get pregnant. That's a key part of the equation. So we put her on mucus enhancers, and
what's a mucus enhancer?
A mucus enhancer is it could be a vitamin or it could be an agent to help increase mucus production. So we have a B6 protocol that that's one of the few things I'm allowed to recommend because it's a water-soluble vitamin. They basically pee out what they don't use. Some of the physicians will use amoxicillin. It's a great mucus enhancer. In fact, even when people are charting, if they're on an antibiotic, it's funny, they'll come back and say, wow, I had a really great mucus cycle. It's like, yeah, the antibiotic will do that. There's also a product, and I'm not sure if I'm pronouncing this correctly, called guafenicin.
Yeah, it's Robitussin.
Yeah, it's in cough syrup. So I've seen people that have been on all three. I've seen on people that'll try the B6 and see if that works for 60 days. So the goal is to try and improve. And even sometimes the whole issue of sperm count comes up. And they'll come to me and they're absolutely devastated because the doctor said there is absolutely no way. There's no way you're going to get pregnant without IVF. So first of all, I reassure them that you only need one. And second, our NaPro doctors have a little different perspective and thought process on that. So we really try and enhance the factors in the male and female to improve, to prove the possibility of them conceiving. And we have seen couples conceive who were told that they were basically IVF's your only answer. Even the PMS, it was a little bit painful to write, to think about that time period in my life. But with PMS treatment, a lot of times antidepressants might be recommended. And what they have found over the years is that some of those antidepressants actually can block further progesterone production. So think about that. You have a woman who is precariously low in progesterone. She goes on an antidepressant, and like some of these tragic cases, I often think I would love to do a profile and see what was actually happening with a woman. And when I first started studying this material, Dr. Hildreth used to talk about women that would come to him and they had been diagnosed as bipolar, severe anxiety, and they corrected the hormones. And the other thing too that I really love about NaProTechnology, when I started treatment, I love the idea that they would try and use the lowest dose possible that might be pharmacologically active. So it wasn't just like throwing medication at you. It was like, well, let's try this. And the shots were incredible at stabilizing my post-peak phase and kind of boosting my system to produce estrogen and progesterone. My kids to this day, we still laugh about mom's happy hormones. Mom's happy pills. But really, in every cycle, it's funny because I did this treatment for 16 some years or so, and in every cycle I'd be dumbfounded, like, oh my gosh, like this is amazing, like I'm so calm.
Progesterone shots, you're saying at the...
The shots are actually HCG, which is human chorionic gonadotropin, which we produce when we're pregnant. So I'm not sure of all the science behind it. I've heard it explained, but essentially it tries to boot your body to produce what you're supposed to produce. So it's not they're not trying to get you to overproduce, but to try and bring you within normal range of function, essentially. So.
With the wedge resection, do you have rates of success?
That's a great question, Dolores. I would have to check with the Institute. I would think that they probably do have some statistics on that.
What does that, what does it do
journals.
again, the wedge resection? What's the purpose of the wedge resection?
So with polycystic ovarian syndrome, sometimes what you'll see on ultrasound, it's almost, they call it like a string of pearls. Not always, but in some cases you might see that. And it's almost like a tougher surface, so to speak. So the idea is to cut into that and to provide a normal space or area, essentially. I think the book does go into a little more scientific detail. But one of our practitioners, she actually started as my client. She was an engineer, and she was so fascinated with the system. She went to be trained, and she had two children after her ovarian wedge resection. Now, I heard you mention something about publication, and that's actually a really good thing that I want to talk about. So anytime you're looking at research on NFP, it's very hard to find good research, because oftentimes what they do when they do research is they lump it all together. So instead of doing research on this system or this system, it might be self-devised systems, combined systems, basically everything together. The other thing, many years ago, there was a study that was done, and they said, well, we looked at 100 users, and 21% became pregnant in the first year. Well, these methods aren't very successful. But what they did not separate out is the fact that some of those couples wanted to be pregnant. Sometimes what might happen is a couple may say initially they're avoiding, and then they may try and achieve. The research has been an ongoing problem. There is somebody by the name of Dr. Joe Stanford that has done research in the Creighton system. Richard Faring with Marquette. There are people that are trying to do this.
Yeah, Richard's published it.
Yeah, I actually love, he's a great speaker.
I just saw them in Nashville.
Yes.
Yeah, he publishes in nursing. He's a nurse, so he publishes in the nursing journals, but they have pretty good science there.
Yeah.
Yeah, and it's over the years. Dr. Hilders is older now, but, excuse me, my allergies have been acting up. It's in his field. You would think that he would be accepted in his field, but he really isn't. This whole concept of not using the birth control pill, some doctors feel that what he's doing is irresponsible because, well, this isn't the standard way that we do things. There have been times when he's tried to get published, and I think after a certain period of time, he just stopped worrying about it, because he was having success with his patients, and he was doing surgery at Creighton, Creighton Medical Center. So I think some of our younger doctors coming in, it's really exciting. The next, 10 to 20 years, I look forward to seeing what's going to be coming out from our younger physicians. So.
And what's been your work with, or efforts in trying to get a physician trained in here in Pittsburgh?
Well, there have been various times throughout the years. UPMC is a big system that is not necessarily receptive, I think, to this type of medicine. Dr. Bruce Mascaronic did do this type of work for a while with his practice, and when he first started, he talked with his partners, and this is what he wanted to do, and it's difficult when you're not, the way that you want to practice medicine isn't necessarily what they want to see you do. And we had a fellow there each year. The Institute has 2 or 3 young doctors that do the fellowship program. And we actually have one of those fellows at Camp Hill now, Naomi Whitaker. And I've had clients go to her and absolutely love her. She's young, she's smart, just really, really ambitious. So the fellows, it's a year program, and they essentially work side by side with Dr. Hilders and his staff, learn all the surgical procedures, techniques, just kind of get to pick his brain essentially for a year. One of the fellows, a couple years ago, was thinking of coming to Pittsburgh. I think his wife was from the Youngstown area, but his wife was also pregnant with her 6th child. That's tough to come in as a new physician and try and build a practice. And so he ended up going out to work with Dr. Christopher Stroud. And if you're not aware of Dr. Chris Stroud, he's another one of our rock stars. He has done some YouTube videos on polycystic ovarian syndrome and endo, and his polycystic ovarian syndrome video, I refer people to it all the time. It's one of the best summaries, especially if you're not medical and trained in nature. But he finds about 50% of his PCOS patients also have endometriosis. I was talking about the difference in laparoscopies. That was another thing that Dr. Hilders talked about, early in our training, that clients would come to him and say, well, I had a lot, everything's fine, everything's normal. So he waited about 6 months and do the near contact procedure and found endo in pretty much almost all of those patients. So.
And where's Dr. Stroud?
Dr. Stroud is in Fort Wayne, Indiana.
Oh, he's in,
Yeah.
that's right, he's in, okay.
Yeah,
And that's where this other fellow went to work.
That's where this other fellow went. Now, there was another doctor.
What's his name, the one that went to work with him?
Blaze Milburn is his name. Now, there was another doctor years ago, Lorna Certinovich, I can't remember the last name. And she did consider, she actually interviewed, I don't know that Mercy was ready, she was a real powerhouse, this little doctor, but she was on fire for what she was doing, and she ended up, I think, going to Michigan.
She didn't come here.
Yeah, she didn't come here. So there has been interest. Part of it too, I know when Blaze was looking at this location, he had asked me, like, well, how many clients do you see? I get a lot of really tough cases, so to manage an individual case takes a lot of time. So I would say like 8 to 12 new clients yearly. I have sometimes transfer clients that come in, and that's been my choice. Up to that point I was working other jobs, so I was doing this as a part-time venture. But it's often like, what's the chicken or the egg analogy? Like, if we had more practitioners, we definitely would have a greater load of clients to refer to him. But it's hard sometimes too to convince them, like, if you build it, they will come.
Right.
I look at Camp Hill. At one point there was a wait list there of over 6 months to get in. Dr. Hilgers, typically if a case goes out to him, we tell people allow 6 to 8 weeks before you even get a reply or response, and so that the need is definitely there. People need the services, but we're just not all over the place right now. So each year, as more doctors come into the program and train, and I think that's a challenge too, to do the medical consultant program. So my program was the practitioner intern program. So I started with initial education phase, which was about 9 or 10 days, I think. And when I went through the program, they actually brought an education program here to Gilmary, and we all went and lived there, and for a week and a half. So once you finish the first education phase, then you go into your first supervised practicum, and everything you do is reviewed. And now we have digital. I was telling Ashley, like, I used to carry a portable copy machine, into my file because I had to make copies of everything. So after that first phase of education phase 1, practicum 1, then you go back for education phase 2, which is about 7 days, and that's where you get into really, advanced cases, moral implications, those kinds of things, advanced case management, and then you go into your second supervised practicum. There are requirements about the number of sessions that you have to do, the number of clients that you have to see. Then at the end, you have a site visit. So my educator came out to Pittsburgh and oversaw me doing an intro session, oversaw some client appointments. Then you have to take a national exam and you have to pass the exam. Then you can actually teach. Now after that process, you have a certain period of time that you have to then go through certification with the academy. So it's pretty, it's a very good program, but it's pretty intense. Now for medical consultants, the same thing. Thank you so much for coming. I hope that we get to talk more.
Send your email.
Okay, awesome.
Thanks for coming.
Nice meeting you.
Now with the medical consultants, they go through a similar process, but when they do their second phase, they actually have to go out to Omaha because they're getting the surgical training. And Dr. Hilgers is funny. If you're an OB-GYN, like, he really doesn't want to hear that you don't want to learn. It's like, you will learn the surgical, which is a good thing because it's such a valuable service.
Do you say there's 2 or 3 that graduate, that finish the fellowship?
Yeah, there's a
every year?
fellowship program. I would say 2 or 3 doctors each year that finish that. So we had for a while, Camp Hill, there was a doctor by the name of Dr. Mark Stegman, and he was probably like second to Dr. Hilgers. He had worked with Dr. Hilgers for years, and we just, he was a very good physician. He would admit that his bedside manner sometimes was not always, and some of the clients would, would report on that, but he was a very good surgeon, very good physician, and he in turn then helped to train Dr. Daggs who was there for a period of time. Now, Dr. Stegman is retired now, I'm not sure where he lives. Dr. Daggs is in North Carolina, I believe. And Doris Millar, who is a nurse who ran the fertility care, like the program out of Camp Hill, she also is in North Carolina now as well. So there's been a little bit of transition.
Do you see a scenario for Bella that we could maybe share a NaPro fellow surgeon with another, I don't know if you heard the story, the Cleveland group that wants to open one as well. And have have practitioners work with patients and clients and couples, and then also have a, not a physician, but a PA or a medical assistant that are trained, that went through the NaPro medical professional training, but not the fellowship.
Right.
Do you see that as a scenario?
I've actually been exploring that and asking some more questions. So I know that, because we have just a couple rare teachers that might be trained in 2 methodologies because they work in a physician's office. Now, if you call it a fertility care center, it has to be Creighton teaching, like my center. Now, the physicians, I know at Camp Hill, they see people that chart with all different methods. Sometimes if they really are experiencing confusion with when to do certain tests, they may refer them back to me and say, look, they have a background, can you get them started, on Creighton? So that's something that maybe the Institute, like Sue Hilders, might be a good person to talk to about, because I think she has seen the development of these kinds of things over the years. But there's definitely people that we could talk to, in terms of, well, how do we proceed, or what's the next step, on that. So, and they wanted me to do there's an educator program that's starting like this week or next week. It's very expensive. I have a daughter getting married next year, so I wasn't sure about taking on that commitment. But the educator program takes an individual who's a practitioner and then trains them to be able to train other practitioners. So it's a different curriculum, and my goal is maybe 2020, October of 2020 possibly, considering that, so that we could get more practitioners. We've had a few practitioners over the years. We have Michelle Boda, I think some of you may know. So she did train, but then she has 2 young children, and it's hard. It's hard trying to find that time when you can meet with clients, and what do you do with your children during that time, because it is a lengthy follow-up. So she got to the point where she needed to do certification, but you have to have materials to teach, and you can't order materials unless you're certified. So I had talked to her about maybe, thank you, that's so kind. I talked to her about maybe, could she work in my center, but she didn't feel comfortable with my fee structure at that point. And I do, there are adjustments. If I have a case, for example, like a single woman that comes in, not genetically active, they're just doing this for health maintenance, I don't advertise that I eventually reduce the fees, but I talk to them at the beginning. So they pay the initial startup, fees that we charge, because that's the same for everybody. But if it's a really simple case, then I do, make adjustments. That's the beauty of being self-employed. I can do that. I don't have somebody over my head saying, well, why did you do that? Why did you give that for free, or why did you? So.
How many practices?
So the midwife, the NP, the PA, if they go through the medical consultant, they can do the first 2 corners of that triangle, right? They can do the targeted hormone
That's a
panel.
good question. Yeah, the targeted hormone evaluation,
The ultrasound?
definitely. Now, the ultrasounds, they might, refer to a facility that would be able to, to do the ultrasounds, or if they have it at their facility.
But can they interpret the ultrasound?
That's a good question. I would think they could, but I can ask. I can find out. Yeah,
Because that would
Allison
be
is a great resource.
That's a.
So the first 2
question.
things, and then the surgical procedure would actually have to be done by a trained OB-GYN.
Which then makes sense if you were sharing, probably a full-time surgeon isn't necessary.
Right.
If you could
bring them in.
have a PA or practitioners or, you know, an NP that
Now,
has been trained.
Dr. Dax, so when we were at the conference this summer, so she's very good friends with Teresa Farmer. They've known each other for years, and she's walking down the hall, and Faith always, you know, it's like fast motion, and she's like, you know, I still have my license in Pennsylvania, like telemedicine, and I was like, did I hear you say that? Are you saying that you could possibly? So, I mean, that might be another possible
Who's that?
resource. Faith Dax, who used to be at Camp Hill.
Okay.
So I think she still has her PA license at this point. And so I guess there is a way to do telemedicine. And you know, when couples come in, I mean, sometimes couples have been through so much that when they come in, they want it all. They want to do it all. I want the hormones evaluated, I want the ultrasound, sign me up for the surgery. But then there's others who may say, you know what, I'm not comfortable with that. You know, I want to do the hormone evaluation first. Let's see what that reveals. So we always try and be respectful of that. You know, that ultimately it is the couple's choice as to how much they pursue and how fast, you know, they go through the process. But we do encourage, I mean, oftentimes the laparoscopies are really a valuable step in the process.
And what's a Da Vinci robot?
It's a mechanical robot to do surgeries. Dr. Dax, I would say she was doing about 75% of her surgeries with the Da Vinci robot.
It's in the medical world, not
They
just
would
the
know,
NaPro
yes.
thing, right?
Correct.
Okay.
That is correct, yes. And even the way we briefly mentioned cervical inflammation, so years ago it was treated, I don't want to say primitive, but it was silver nitrate. They would paint this silver stuff onto the cervix, but it helped to reduce or soothe, you know, the inflammation. Then they started doing something called hyfurcation. So they would need to have a hyfurcator in the medical office to be able to do that. Now, I know Camp Hill, I'm pretty sure that they're doing a cryosurgery procedure now. Like kind of
Can they do that
freezing.
in the office or no?
I think they do. I think they do, but I can find out. Send me all those questions, and I'll ask the doctors. Yeah, it's funny on our practitioners page, it's such a great resource because something will come up. I mean, I've been teaching for 20 years, and it's still, you know, you could walk in with a chart and I could see something completely different, you know, that maybe I didn't see before, so.
And how many practitioners are there?
Nationwide, I can find out.
Yes,
I mean, some areas, that's a good question. There are some areas in the country, for example, St. Louis, where they actually have it as part of the hospital system. They have, you know, a number of practitioners. Omaha, so Omaha, St. Louis, there's, I think Dallas, Texas is a big center. So there's different parts of the nation where you'll find a full staff. Most of us, though, are really independent practitioners. We just kind of operate on our own and try and run our businesses on our own. So,
How much does it cost to do the training that you're considering for 2020?
when I looked into it, I want to say it was around 6,200. I think that was it. Now that wouldn't include airfare and hotel. So yeah.
To go to Omaha, it's all
go to
takes place in, okay.
Now there are.
And how long?
That actually raises a good question. So there are other education programs. Omaha is the home-based education, and everybody typically likes to go there because it's the source of all things Creighton Pro. But there are other education programs. St. Louis does an education program. When I did my program, Kathy Rivet was my supervisor and educator. She's based in Nashua, New Hampshire. So she got another educator, and they brought the program here to Pittsburgh. And so we did have people from different states, and you know, they came in and did the program. Now, some educators, I think the Institute would love that if they trained me or anybody else as an educator, they want you to develop your own education program. But that's not always possible. So some people, I think Kathy Hercala might be one of these. She's out there in West Virginia. She is on the faculty of St. Polycystic, so I think she travels. They just sent a group to Mexico. They went to Poland a couple years ago, so they're really working on some international initiatives that are pretty exciting.
So the cervical inflammation, that would be something that the ultrasound can detect? in that second?
No, actually, the cervical inflammation, we look at their chart and we do, we look for certain criteria during the pre-peak phase, certain appearance of mucus during the post-peak phase. So an OB-GYN on an exam can determine if there's inflammation present and then treat it in office.
What would be the 6 things that it can detect then on the ultrasound?
Oh, the ovulatory disorders, those actually are listed in the textbook. Yeah, there's some related to, how the follicle is developing. Sometimes if the hormone levels are off, it's almost like a domino effect. If one thing is off, then it affects everything else down the line.
So they can see that though on the ultrasound, or they can diagnose
they
it
do
from the
that
ultrasound.
and that's, a physician would probably be able to give you a better medical answer, but.
What causes cervical inflammation?
That's a good question also. So there's a number of things. There could be something called cervicitis, which is a bacterial infection of the cervix. Sometimes if you look at the shape of the cervix, if there's like erosion, either childbirth or scarring, there could be erosion that causes that. If the shape of either inversion, eversion, the shape of the cervix is different, it can change that. And so I actually had a case, this was very early on in teaching, and she was one of the few people I'm like, this is the first normal chart I have seen ever in these years of teaching. So she started to notice an unusual discharge. And women that are charting tend to pick up on abnormalities so much quicker than if they're not paying attention to that. So I said, we always refer back to the physician. We respect the physician's expertise and knowledge. And I said, go see your physician, tell him what's happening. Well, he was just fascinated. He said, how did you know that you had cervicitis? So of course she played dumb. Well, I saw this on the chart. But the chart, and so she went on antibiotics, and within another cycle it was cleared up, and she was back to her normal pattern of charting. When I first started, my first 10 cases, I came home in tears the one night because I thought, none of these, not a single one of these look anything remotely like what was in the textbook. And my educator just kind of, after she finished laughing, she said, welcome to the world of women's cycles, so. But, I have one, I forgot to mention this too, so, the pregnancy dating, this is something else. So anybody that becomes pregnant in our program that's an active client, one of the free services I provide is something called a pregnancy evaluation. So we sit down, it's kind of like a follow-up, but we look at the chart, we look at circumstances, and we have a short form and a long form. So the short form is, yes, they were trying to get pregnant, yes, they knew they used days of fertility, and now they're pregnant. The long form might be somebody that, I was using the system to avoid, I'm not really sure how this happened, so it's a much more in-depth evaluation. But the pregnancy evaluation really gives keys to behavior because, anybody can learn a system of NFP, you follow the mechanics and learn the guidelines for your particular system. But we also look at things like behavioral aspects as well. And the first thing is when we date the pregnancy, most standard OB-GYNs will date the pregnancy, they'll ask what's the last menstrual period. We don't do that. We actually look at the chart and we look at where's the window of fertility, how many acts of intercourse occurred. We come up with a midpoint, we come up with a range, and it's always kind of fun to see whose date's more accurate, our date or their date. Now, if you have regular cycles, the dates are going to be pretty, pretty equal. But I have a client, she has 5 children. She just unfortunately had a miscarriage, but her cycles are longer. Her cycles are 44 to 45 days. That's her normal. And so if they were dating based on last menstrual period, this would be a problem because doctors get a bit nervous if you start going over your due date. She had her charts for each of her pregnancies. Fortunately, she found a physician who was very receptive and supportive of this. She never had C-sections. All of her babies arrived right on schedule based on, how we dated the pregnancy. So that helped to avoid, surgical intervention when she didn't really need it. She knew when she had conceived. Now, we talk a lot too with behavioral aspects, and when we did the presentation at Jennifer and Ivan's house, we got into this a little bit, that, behavioral aspects, they don't teach you this in your training, but that has been the most fascinating thing to see over 20 years. And I had a couple once that they came in and they got married a little bit later. I think they were in their 30s, and they wanted a family, but they wanted to learn this system first and understand what was going on. And every follow-up, they would come in and he would like slam his hand on, nope, we are using this system to avoid pregnancy. So I'd open the chart up and I'd say, oh, I see that you changed to achieving related behavior, and they would argue with me, no, we didn't. And so I'd say, well, did you understand? Let's go through, you tell me, what days did you think were days of fertility? So I went back and I asked my supervisor, I said, what am I missing here? What's going on? So as I continued to ask some leading questions, it was really sweet. Like they wanted the element of surprise. They didn't want to say that they were trying to achieve. They wanted it to kind of be a surprise. They also didn't want to be disappointed. They felt like if they said they were trying to achieve and it didn't happen, they would feel disappointed. So all of these little behavioral aspects came in, and they did go on. They had, I think, 6 kids in 8 years with 2 sets of twins, actually. So fertility was not an issue, but I was always like fascinated. And on the reverse side, I had a couple ones that was dealing with primary infertility, and they weren't using days of fertility necessarily every cycle. So as we delved a little bit deeper, there were some counseling issues that I referred for, and I think there had been some abuse, prior. So there can be a number of factors. So we try and identify that and then refer them to the appropriate, people if that's the case. And she did actually. She went on to have, I know she had at least one child. So, but the behavioral issues. Dr. Hilgers has a statement that achieving related behavior often precedes achieving related intention. So we'll see signs of that in the chart, like maybe they're not observing, maybe they're only observing 50% on some days. Maybe they start using peak +3, which is a day of fertility. So they'll come in and they think it's a big surprise, that they're pregnant. It's like, and I just smile because I've seen this, possibly coming along, for a while. So yeah, I love. I'm very passionate about this stuff. I love this work.
You can tell.
Yes, you can tell.
Yeah. Thanks so much.
You're welcome. And I'm just an email away, so if you go home and you think of another question, please feel free to reach out to me. And I'm always open to do individual talks on different topics if that's something.
Yeah, we might gather again with the priests that weren't able to come after they watch the video, and maybe just, we're a couple steps closer to planning Bella than we had been, and maybe just get more stakeholders in the room that would be interested in hearing.
The first time, I literally couldn't sleep that night. I was so excited to hear all this stuff, because it's things that we've talked about. And when you're an individual practitioner, how do you make that happen? But it's really neat to see all these individual players who have come into the discussion and they know the work. So it's really exciting.
And just keep us in mind when, I know you will, but just, that is what we're gathering, the medical professionals that could, the key surgeon and physician.
Oh, every year I tell Sue, I'm like, do you have any friends that might want to come to Pennsylvania?
But the thing is, I think the difference probably now in your conversations would be that they wouldn't have to start the practice.
Exactly.
We could start the practice.
Yes.
They just come work at the practice.
Right.
We would set up the
I think that
infrastructure.
is
They would
smart.
have all the support staff and they wouldn't have to do that. I don't think a lot of doctors are necessarily interested in starting practices. They just want to come and practice, and
Be
that's
able to do
understandable. They
yeah.
spent their careers training for that. They don't want to have to go start a business. So I think it's much more attractive, that would, knowing that scenario, as opposed to thinking,
yes.
oh, should I go to Pittsburgh and start a practice? No, just, we'll hire you. So anyway,
Awesome.
I throw that out.
Okay. All right. Thank you so much.
All right, thank you.
Such a